I think one of the question is basically for those patients who may be perceived as too good for studies, what is that all about? And I think clinical trials and everything in medicine, whether research or not, is really about risk and benefit, right? And so if a patient, for example, has too little disease to measure, I often use this analogy like weight loss, right? So if you're trying to lose 20 pounds, you can do a new intervention and see if the plan is gonna work. If you're trying to lose 1 pound, that's gonna be variable, like based on your bowel movement, your clothing, and what you drank, right? And so the problem with myeloma patients who have too little protein, if your M spike is less than 0.5, like say it's 0.3, your light chains are 20, if depending on your units, 20 or 2, that's like the 1 pound situation. And it could fluctuate, and by the time you start the treatment, it'll be very hard to know if the treatment's working or it's just fluctuation. And so that's why all clinical trials, that's one of the most common reasons patients may not be eligible, is you need to have what's called measurable disease. And otherwise, we don't know if the drug's working, right? And what's interesting is actually, that makes one of our jobs a little bit easier. If we were solid tumor doctors, often we don't have these proteins. They have to do scans all the time, right? So one of the nice things about myeloma is you have a very easily doable blood test, but unfortunately not everybody will meet those criteria. So that's the reason for that. And then the second reason is also if your myeloma is well controlled. There are other studies. So for example, there's a clinical trial now that for patients who've had transplant, who've had a good response and everything's gone, but they have that minimal residual disease positivity. There are clinical trials to say randomized to 1 drug versus 2 drug. And so that's an example of where you have very little disease, and so you could participate as a patient, but that's very different than heavily treated patients where the current treatment might be working, your numbers aren't going up enough, and therefore, so it really depends on the question being asked, but if it's maintenance disease or extending remission, you could have very little disease. But for most clinical trials which are trying to actively control the disease, I think the question is that who should be making that decision, and is it the patient, the institution, or the pharmaceutical company, which is often sponsoring it? And I think it, first and foremost is that to recognize, you saw how lengthy that process is, and every clinical trial, which is essentially the handbook by which we all use if a patient enters, is fully vetted. It starts with the company or the physician that writes the protocol. It then is reviewed by the FDA, then comes back to the physician or the company. Then it goes to multiple committees within each institution. And so by the time this is all done, we have to agree on everything that's laid out there. If any of us deviate from that protocol, it literally is called a deviation, right? And we're held accountable for that. Why are you deviating from the protocol? And the intent of all of this is to protect the patient, right? You don't want to expose healthy patients, and that goes back to my smoldering discussion, right? Is it acceptable to have even 1 heart failure, 1 death in a smoldering population? These patients were going to live perfectly fine, right? So that's why these are so regulated. It's to protect patient safety. So we're thrilled that patients want to participate, but we have to keep patients' health first and foremost in mind. I don't know if anybody wants to add. Yeah.
Oh, so I would just say that, I think that was very well put, but the other thing is you have to remember that the reason the clinical trial is being done is to try and move the field forward. And so if, for example, in the case of having patients who may already be in a certain remission, well, when you analyze the data for that study, they may not be able to show that they have a response rate of 50% because half the patients didn't respond. But in truth is because you can't assess the response. So in a way, if you're going away from trying to answer the question, you might actually delay that process even further. And so that's why there's all these different, this is in place, but at the same time, it sort of kind of comes down to, it's kind of like in politics, right? The difference between doing something for society as a whole versus the individual. And that's when it gets really tricky, when you're the individual versus what's best for the whole group.
There are a lot of ways for us and a lot of tools at our disposal now and some that are coming down the pipeline that help us answer the question, which is what other tools are available for understanding the genetics of myeloma. Our most traditional is literally growing your chromosomes in a petri dish. That is kind of old traditional that's becoming, more and more kind of out of phase. The next step was FISH, which is a means of us asking a specific question. Do you have translocation 1114 or not? It's literally a way to stick it in there and hope you get it back. Further, you were able to the pathologist can subsequently look for the expression of 1114. So 1114 is a specific mutation that has an expression of a certain protein. So the pathologists are able to actually calculate or understand if that protein is expressing that mutation. So there's other stains, I guess I would say, that they can do to assess that. That is a little more experimental. Some sites have that, some don't and are not routinely checking for it quite yet. There is some excitement from ASH recently about mass spectroscopy, which is potentially a manner of that maybe will replace the M-spike someday as a means of quantifying how much protein is in your bloodstream. That could be quantified at the most minute of levels. The M-spike as it stands right now is a good test, but probably needs some certain amount to be detected. By doing it at these very, very low levels, we're going to eventually be able to pick up very low level amounts in the bloodstream. Next-gen sequencing, we hear a lot specifically within the space of what's called minimal residual disease, which is a way to literally get a barcode of your myeloma, or a thumbprint, I like to say, so that when we originally find your myeloma and find the associated barcode with it, we can then look at subsequent bone marrow biopsies and see if we can find that barcode there. And that is a way to look for myeloma that's hidden so far under the surface that our fancy microscopes and tools that we have are not able to pick it up. It's a way for it to look under the surface that way. Flow cytometry is a way that's been evaluated as well. It's a way for us to look for very specific markers or those tags on the cells on the surface of the plasma cells or the myeloma cells. There's next-gen flow cytometry as well. All of those are basically looking at 1 million cells, hopefully, and saying, is there one cell out of that 1 million that still has any evidence of myeloma still left over? So you're asking the right question. For now, kind of mainstream and what's available from the majority of hospitals that are out there is really FISH, maybe some expression testing. The next-gen sequencing can be done commercially. That is approved by the FDA. The rest of it's kind of all still in works. I'll let the scientists answer more.
That's an awesome question, and obviously I agree with everything that Dr. Costello mentioned in terms of the future tests and what we can be looking for. But I'll get to your point because I think you're asking about next generation sequencing in terms of mutations and molecular changes in addition to what Dr. Costello was referring as. So let's think about it this way. First of all, you talked about 1114. What are these translocations? We talk about them all the time. These translocations are errors in cut and pasting DNA. They are very early events in myeloma. They often set off MGUS. They were discovered in the 90s. We talk about them 25 years later, and actually about 10 years after they were first discovered, they became part of our risk stratification. So if you think about the tree we were talking about, we're talking about the trunk, right? And then we know that when you start branching off into these different clones, there are additional mutations that generate those branches and push the disease forward to progress clinically to the point that it is diagnosed and it starts causing trouble to the patient. The trunk abnormalities were discovered in the 90s, the translocations. Those branch abnormalities, the mutations, the first paper was 2011, the second paper is 2014. They are much newer developments. So we know more about what the translocations mean for each patient's disease than how to tackle the mutations that cause disease progression. For a lot of them, we don't have drugs, or drugs are in development, or my mice are seeing the drugs right now. And so in the future, when we talk about 10, 15 years from now, we will start again with clinical trials where we will incorporate mutation profiling and next generation sequencing for mutations when we have drugs that we think will be effective against them. So I think that right now you can get this information. It's just hard to know what to do with it outside of clinical trials. Point number one. Point number two is that with the way the field is moving, and that's actually one of my focus of work and research, is that we will be offering patient therapeutic options initially within trials, obviously, that take into account each of these mutations that each patient's myeloma has. We will be looking forward towards ushering an era of targeted therapy in myeloma. In that concept, we're behind in myeloma than a lot of our colleagues in other hematological malignancies and solid tumors. So stay tuned. We'll all need to stay tuned.
Just one. We've been doing, there's also next-gen sequencing being done in advanced patients. And at Mount Sinai, we have the ability to do targeted biopsies. So we've often done paired biopsies. So for example, a patient has a growing lump in the chest wall, and then they also have a random bone marrow biopsy. And what we found is that sometimes these lumps that are not in the well-behaved areas of the bone marrow have additional genetic hits that are potentially targetable by drugs. But it goes back to the branching tree that Dr. Asimakopoulos, I'll just call him POTUS. What we've seen, though, and what's great about doing that is you can identify potential new targets for patients. So for example, there's a mutation called BRAF, which is a mutation that's found in melanoma cells, and there are drugs available to target that. And so when we have a next-gen sequencing done, that allows us to appeal to the insurance company and say, this patient has heavily treated myeloma. Can we please get this drug for this patient? Here's the proof that there's this mutation. The challenge, though, is it's that clonal heterogeneity again. What we've seen in doing that in our patients so far, and we've been doing a lot of paired specimens, you often find something wrong in the poorly behaved site that's not in the regular bone marrow site. Both have myeloma, but just different kinds of myeloma in the same patient at the same time. But targeting that one thing it only helps that potential one site. So you can't just throw all your eggs at one. It's like a leaking bucket, and you're just plugging in one hole. Ideally, you need to coat the whole bucket, and so you need combination strategies. And I think that's one of the challenges right now is we can find these specific abnormalities, but not enough to just target that one abnormality.
Can I say one thing? So I completely agree with everything that's been said, but I think we're actually moving in that direction a little bit. So I think if you can have that done, you may want to consider, insurance may not pay for it, so just realize. So you want to make sure that insurance pays for it, or sign up for somebody's research who may be doing it that can do it for you. But there will be these trials that are starting now and in the future where you will have things like that, where if you know you have this particular mutation, you will get treatment for your myeloma with carfilzomib, pomalidomide, for example, backbone, and then you may get added that drug specifically, and so you might fit into that tree. So those trials are coming up. They're in the future. So if you're able to get that level of information, we may not know what to do with it now, just like we talked about before, but it may give you options later on.
Do you want to do it? Or I mean, I'll just start with so the question is about transmission and hereditability in the family, not just genetics in the patient. So I think this has been studied quite a bit in some ways, but not other ways. So if you look at most patients with myeloma, they don't have a family member that has myeloma. And I would, you saw some interesting HealthTree data, but I would broaden that to say it's not just myeloma, it could be other sister cancers. So the broader categories, B-cell malignancies, lymphomas, CLL, et cetera. So most patients with myeloma don't have a related person, but if you do large population studies, it's a 2 to 3-fold higher risk that if there's a patient with myeloma, somebody in the surrounding environment. But I would add that though, FISH is not enough. Remember, as you've heard, you can have the same abnormalities in myeloma that you do in smoldering and in MGUS. So just having that abnormality is not, it's neither necessary nor sufficient, which are scientific terms, meaning if you just put that into a normal plasma cell, that in and of itself is not enough to cause rip-roaring myeloma. And I think a large part of that, and I think in talking about the future, is we have to stop separating out the genomics from the immunology, right? Because when you just look at the plasma cell, you're missing half the story, which is what's happening in the bone marrow microenvironment. For example, you can have 2 patients that are both MRD positive. One has a favorable immune system, the other one doesn't. And that their outcomes will be very different, right? So I think the genetics is part of the story, but the other very important part is the immunology part. And I think the reason I was bringing this up was also, let's just say that a family member has that. We know, I think there was a very interesting study in Blood where you could ask this question of, if I'm diagnosed with myeloma, how long has this been there? Or might it have been missed, or could it picked up earlier? Which is another way of asking your question. And generally, who's running around getting SPEPs, light chains, UPEPs, right? No one. Your primary doctors are not doing that. But the vets donated blood to in a study, and they took newly diagnosed patients and went back 1 year prior. 100% of patients had detectable paraproteins, meaning myeloma proteins. When you go back 8 years, it was 80%. So that means that most patients have had this in their system for a while, and so you could, the problem with testing early, in medicine, when we do screening tests, it has to have a very high threshold, because sometimes when you diagnose people with things, it adds to anxiety, and it doesn't change the management, right? So every time I see an MGUS or smoldering myeloma patient, I said, look, you're coming in this room the same way you're leaving this room. I mean, and you knew, but now that we give you a label, your life doesn't have to revolve around this label, right? It's important to pay attention to, but if you've had MGUS for 8 years before your myeloma and didn't know about it, what would we have done differently? So until we get to the drivers of myeloma, so it's not just a single mutation, until we integrate it with the immune microenvironment, and then we come up with strategies to block the progression, knowing about it isn't always going to change our management, right? It's not always a satisfying answer to hear, but it's important because I think we don't screen for all cancers, right? So if a patient, if you look at all the possible cancers in the human body, very few of them result in family screenings earlier. A good example would be breast cancer or colon cancer, I think, where if you have a patient, then you screen earlier in relatives, but that would be my take, but add.
Well, I would say that what you passed, the DNA you pass to your kid is the DNA in a sperm if you're a boy and an egg if you're a girl. The myeloma initiating mutations, like an 11-14 translocation or a translocation, happen in an immune cell in the body of an adult individual. So so you can see the difference. So it is not hereditary in that classical sense. But there is a chance that in some families there may be some propensity to develop that event that will set off myeloma in the immune cell. So like, you know, there are some families where high blood pressure runs or cardiac disease. It doesn't mean that everybody will get the condition we are talking about. But the mutations, the translocations that set off myeloma need an immune cell to basically set the stage for myeloma. And that is a cell that will be part of the immune system of an adult individual. So there are two separate things. So it's not that you will pass it to your kids in that classical sense. And as Dr. Chari was saying, it's a multifactorial disease. There are a number of things that contribute a little bit. But I think that when patients ask us this question, I think the answer is pretty simple, that it is not a hereditary cancer in the classical sense.
Right, so I think the question is 3 plasmacytomas, i.e. myeloma, on Revlimid for 6.5 years. What does that mean for relapse? So you first bring up a very important point that myeloma is very heterogeneous in how it presents. Some patients have hypercalcemia, some have bone disease, some have anemia. Multiple myeloma, so multiple plasmacytomas meets the definition of myeloma, regardless of whether you have bone marrow involvement or not, right? So we typically say myeloma requires 10% or higher plasma cells, but it doesn't matter if you have multiple, because if you have multiple spots, you're not gonna go sitting there hacking out or radiating every spot. You wanna treat the whole body, because otherwise you're gonna get new disease. So the treatment is fine. I think, and this brings up a very important point, which is we talked a lot about the crystal ball, the initial diagnosis, the FISH, the next-gen sequencing, and predicting. But much more important than that is what actually happens to the patient, right? Functional risk. So somebody may have standard risk everything, and you get standard chemotherapy, and the remission is very short. That's a high-risk patient. Even if you can't say what made them high risk yet in current technology, short remissions are the definition of high risk. Long remissions are the definition of standard risk. Now, obviously, that's a little bit integrated with the therapy, because the question in your case would be, for example, is your remission lasting that long because of the Revlimid or not, right? And that's a really tough question to answer, because the only way we can answer those kinds of questions, you got to take large groups of patients and randomize them to treatment or not, or discontinuation or not. And generally, as I alluded to, if very few patients are being cured yet, we're always a little hesitant to discontinue therapy, especially if it's being tolerated well. And also, scientifically, we don't really know, is somebody's remission lasting long because they're exquisitely sensitive to that drug, or is that really favorable biology? So, and that's a really tough question to answer. And I think one of the ways we need to do that is by taking standard risk patients, doing complete imaging, lab testing, doing that marrow, doing that MRD testing to look for that 1 in a million cell. And if we don't see it, then we'll need to do prospective studies saying, okay, for low-risk patient, let's stop therapy going forward in these patients. So right now we have a data gap. We don't have any of that information. And so a huge part of your question is how you're tolerating it, right? So if you are having difficulty tolerating, so to me, the use of MRD is a little bit controversial in the sense of, we always tell medical students, if you're gonna order a test on your patient, that you should be prepared to answer that patient's question of, how will this change my management? Right? And so if you do the MRD test, and if it's, whether it's positive or negative, you're not changing, well, then why did you do that test, right? But I think the place to start with right now would be in low-risk patients who are in remission and MRD negative, can we start doing studies to discontinue therapy on those patients? We don't know, right? Because again, the low-risk patients are the ones who've been doing well, and is that because they're doing well because of the therapies, right? So I think it's a tough question to answer. If you're tolerating it well, you would continue. But to answer my final point is, if you had such a long remission, this bodes very well, right? That this is a good myeloma if your first remission is that long.
Oh, yes. So post-transplant, is it still common to have 1 drug versus 3 drugs as maintenance? That was the question, right? So, so that's actually a very interesting point. The answer is we don't know. The traditional, if you have the large studies that were done in frontline myeloma, taking all patients, looking at that whole idea of induction with the 3 drugs, getting you into a certain remission, having your stem cell transplant, and then going on maintenance, we're done with usually 1 drug, whether it was Revlimid or whether it was Velcade or whether it was Ninlaro. And so those studies showed us that being on that 1 drug was superior to not being on anything. There is some data in smaller studies when patients who are high risk, as defined usually by the cytogenetics, that patients with certain characteristics that make them high risk may benefit from one drug versus the other and possibly combination. And so if you're high risk, your doctor may actually talk to you about continuation of therapy more than just maintenance, and you go back potentially to the same 3 drugs that you started, and you maintain on those, perhaps at lower doses, but you maintain the multiple drug effect because there's that fear that one is just not going to be sufficient. And so that may be why your doctor may have talked to you about staying on 3 drugs.
I would just add that there's also the consolidation term, right? So there's induction or initial therapy, transplant consolidation, but sometimes there's also consolidation after transplant, and that is often 3 drugs get used. And it's always interesting when you cross the Atlantic and management changes, right? But across the Atlantic in Europe, they tend to do a lot more consolidation. My belief is because they don't have as much access to novel drugs. So if you get kind of old school regimens, you get your transplant, more of those patients are not getting into completely deep remissions. So then they need to use these 3 drug combinations because this is like a boxing match, right? The myeloma is the opponent, you're trying to get a knockout punch. And what happens is after induction and transplant, your opponent's down, but not completely. This is your best chance to get that knockout, right? So if you've had a deep remission, but there's a little bit of myeloma left, pummeling it with 3-drug regimen for a short period of time is what we do as consolidation. And so in some studies that can be helpful to eradicate that little bit of disease, but it's not intended to be necessarily 3 drugs forever. It's for 2 to 4 months, and then you go on to your maintenance single agent drug. So that's another kind of twist that some centers use based on patient response.
So the question is for someone who is newly diagnosed and about to start treatment for their multiple myeloma, although this could probably be across the board for anyone who's on treatment for their myeloma, what are our opinions on complementary or more holistic medications that you talk about, or hear about, I should say? This is right. What I usually say to patients is, we are scientists. We believe in science, which means we believe in data, which means that we believe that something is proven to be effective and something is proven to be safe. For better or for worse, there's not a lot of money, because that's what it comes down to, about studying some of these more holistic approaches. And so there are really nice, for example, Memorial Sloan Kettering has a really nice app out there. I think it's called About Herbs. I have it on my phone because I have many patients who come in and say, what about this? What about these turkey tail mushrooms? And I say, I don't know anything about turkey tail or mushrooms, but whatever literature is out there about some of these supplements that patients are interested about, it'll be in this app. It'll spit it out, and you can say, these supplements with this disease, what do we know about it? This is what it is. And so because there's just not a lot of knowledge out there because it just hasn't been studied. When I broadly approach it, I like to make sure I say that my greatest concern is that anything that may interfere with what I know works. And so, for example, there is documented evidence out there that green tea extract is concerning in how it may interfere with Velcade, for example. So very specific that you're not supposed to take those 2 on the same day. But there's very little additional information that's out there about some of these other supplements that are available. So I generally approach it to say is, again, your body, you do you. But what I want to make sure is that I can say is, if it isn't gonna hurt you, I just don't know. And it's hard to make, I think, recommendations on our end without true evidence behind it. Yes, right. What supplements can we use to help your immune system fight? Yes, and gosh, will we be out of business? I think I'd say show me the money. what it comes down to, there is a lot out there, and I think sometimes it's misleading. There is a nice breast cancer study that was out there that was put out of Yale recently of women who, with breast cancer, decided to try a holistic approach versus try a chemotherapy, and the difference in survival was remarkable. And so while you're not asking about one or the other, I think what we cannot answer is maybe it'll help your immune system, but is it possible to interfere with the drugs that we know are effective?
I would just, it's interesting. My mother has a PhD in math, but she's willing to take any supplement without any critical thinking. But any medication, prescription medication, gets scrutinized to the nth degree. So I've given up trying to work with her. But I think we have to remember that there are drugs like Taxol, which came from trees, right? And aspirin and digitalis. These are all herb-derived medications. And in myeloma, we know that green tea, resveratrol, curcumin, vitamin C, all in the laboratory kill plasma cells. But that those same things in human beings, we don't know if one of the biggest problems with all of these is we don't know what's in these bottles, right? These are not FDA regulated. They could have contaminants. We know that, for example, Chinese herbs can cause liver dysfunction. And I would just make a plea for somebody who's about to start chemo. You're already starting, talk about science. You're starting potentially daratumumab, bortezomib, lenalidomide, and dex, aspirin, and acyclovir to prevent shingles. You're already starting on 6 different new treatments. Do we really want to introduce more variables till we at least know that the myeloma is responding and that you're tolerating it as expected? Once your disease is in remission, have a discussion and say, can I start this product? Can I start this product? But why would you want to add 2 more variables to already very complicated regimen, right? That would be my only suggestion.
We've clearly heard this question.
Yeah, we'll probably hear from his mother as well, because we need the other side, right? So the one thing that is slightly sobering that I would bring up here is that if you think about it, this is a cancer of the immune system. So because patients bring up this, and that you're coming from the right angle, because half of my research is immunotherapy, trying to get the good part of the immune system. But here you may not actually be able to predict the effect. It may not be as simple as you think. You're right, that's what we want to do. It's a cancer that is exquisitely sensitive to what happens around it, and it's a cancer that makes sure to inactivate the good part of the immune system. But something that you get from CVS or wherever that says boosts the immune system can do for the rogue members of the party versus the good members of the party may not be that easy to predict. So that's where some caution is due. And as we heard in the news the last few days, in God we trust, for the rest we need data. So.
This has been published in Blood by our colleague, Dr. Barloghi, who many of you know and Greg mentioned. And he's now retired. But, I think you're hearing these long-term remissions, right? Off therapy. So there are patients out there. It's a statistics question, though, right? And like I said, it's a 2-part question. Can you reliably identify to a high degree of certainty that there's no myeloma left? And secondly, are you that confident that you can discontinue the therapy, right? So for example, even the MRD question is not as simple. Okay, so let's say you've gotten your initial therapy, transplant, you're done, and you're now MRD negative. We cannot detect any molecule of myeloma in your body. But there's another important part, which is the sustaining of MRD, right? So what if at that moment it's gone, but then you repeat the marrow 6 months later and it's back, right? And so there's an important part of MRD assessment that we haven't talked about. I mean, I think how to use it, again, is a difficult question, but a key component has to be sustaining these responses. You could also flip it the opposite, right? There are patients who don't necessarily get to MRD negativity. They have a little bit of M spike left, but that's stable month after month, year after year, and that patient has not been cured, but functionally in a way they're cured, right? Like, because You talk about, we said that if the number one thing is the duration of remission trumps all your prognostication, and if that first treatment is lasting forever, that could be a functional cure. So I think the challenge is the discontinuation of therapy, which I struggle with, right? So you may have a patient who's in remission for a long time or has a stable amount of disease, but how comfortable do we feel about discontinuing therapy? And I'll let you guys speak.
And this is why we never say the word cure, because then he gets in trouble. But I think it's true. I mean, I think all the patients who we think may be cured is based on data that it was collected over the last 30 years or so, right? So again, we don't have a way, the magic ball to say which one of you is in that 10%. Right, so that doesn't really affect your treatment in real life. But I think the trials that we talked about that are starting actually already, where we're looking at, we're getting such potent therapies, where we're getting people into such deep remissions that we're now asking the questions, can we actually stop therapy in a group of patients, will ultimately help us kind of get those answers, but it will take years.
Yeah, absolutely. So, as you know, myeloma is officially recognized by the VA as a disease linked to Agent Orange. And the institution where I came from, to UCSD, UW-Madison, I arrived here this past summer. There was a hotspot of myeloma in Fox Valley, Wisconsin, attributed to herbicides, pesticides, a lot of farming there. So definitely there are environmental causes for myeloma. So, okay, the way that when I discuss with patients about this, or how did this all start, myeloma starts from mistakes that happen during immune cell development. Your immune system is a continuously self-renewing system because it needs to be on high alert. You always have things to deal with. Now it's the coronavirus. Next month it will be something else. So you need an immune system, and you have blood cells that go through life cycles. When the blood cells develop, nothing in life is 100%. There is a lot of cut and pasting of DNA. We won't go into why this happens or why this needs to happen. But nothing is error-proof. So you have mistakes that lead to those translocations. Translocations essentially means I shouldn't be next to this part of DNA. That's not a good part of DNA to be next to. So the 11 and 14 are two different components. They are not normally supposed in the 11-14 translocation. In a normal cell, those two parts, let's call it the 11 and the 14, are not supposed to be next to each other. But what happens is that there are mistakes in cutting and pasting DNA, and they're random. This is probably the answer to your question. It will happen in some people at some point, and it will set the stage for something. And there is not much we can do to prevent that because it's part of the normal life cycle of an immune cell. Nothing in life is 100%. The 11 and the 14 should not be next to each other, but hey, rarely a mistake brings them together. Once they are next to each other, then the cell considers this as something that gives it extra powers. And either the power to divide faster or the power to live longer. And for the immune cell becomes power hungry. And it's a little bit, I guess, dumb at that point. So it really wants to divide itself actually and conquer and rule the rest of the immune system. So that's the beginning of myeloma. Now, some of these environmental influences make this process easier or increase the chance that mistakes will happen. There is a wired propensity for mistake in everything we do. There is a risk in everything that, we're human beings, we live in a living world, and, nothing is 100%. But things like Agent Orange or pesticides or herbicides, they increase the chance for these mistakes to happen. Once the first mistake happens, that 11 gets next to the 14, it's more likely that a second mistake will happen, and then we'll have the beginning of that branching process that will lead to myeloma being diagnosed. So myeloma comes from random events that are linked to blood cell development and immune cell development, and some environmental influences increase the chances for these random events to happen.
I would say generally yes. In my experience, companies have continued that.
But there's actually, the short answer though is no. There is no legal, but in general, I've never had it where they've withdrawn the drug, but there is no legal, anything saying that they have
Usually
to.
what happens is once the drug is approved, it's typically they ask that we go through the insurance approval process, and if there's any hiccups or denials, then they will offer the drug in a special program for that patient. They're sometimes called rollover studies or those kinds of things.
So the question is, if you go on a CAR T study now and you recur, your disease recurs, and are you eligible for a CAR T study in the future with a new generation CAR T or maybe a better CAR T? And the answer is it depends. Potentially yes. So for example, right now, if you had a CAR T and you progressed on a CAR T that was directed against this protein called BCMA, all the other CAR T studies, except for one, allows patients who had prior CAR Ts against BCMA. The hope is that because no new CAR T trying to figure out if their CAR T works wants to test it in patients that already failed the CAR T, because they feel like that kind of sort of stacks the deck against them. But what we're all hoping is that as we learn a lot more about why some patients fail the CAR T or that they come back after the CAR T, that it has nothing to do with losing that protein. A lot more of these other new studies are allowing patients who've had it before. So I think it will depend on the study, but most likely eventually, hopefully the answer is yes.